I couldn't give any comments without mentioning President Owen, who has been very instrumental in moving the Master Educator Guild to the next level. That we've certainly seen a renewed enthusiasm in the educational mission of UMDNJ, all 8 schools, because of President Owen and the support that he's given to all educational ventures, activities, and goals, including our Master Educator Guild. This morning we have a very special guest who actually trained with Dr. Denise Rogers. They were residents together, and
I was her resident. She was my
I don't know if everyone heard that, but we've set the stage correctly that they taught each other. Dr. Charon comes to us from Columbia. She trained at Harvard Medical School and at the Ben Salem College at Fordham University, where she received her undergraduate degree. And I think what's special about our guest speaker is that she's a pioneer. Before it became fashionable to talk to patients and to consider narrative medicine a specialty that's important for all healthcare providers, whether you're a dentist, a physical therapist, a physician, that the patient-to-patient interaction is truly key. And we really didn't look at it seriously and really try to explain what works, what doesn't work with our patients, what really enhances their health care, until Dr. Charon came along and really looked very carefully at this area. And this is what she's going to talk to us about this morning. So without further ado, Dr. Charon.
Thank you for letting me take part in this celebration. It's a celebration of teachers. It is indeed about being clinicians, about taking care of the sick. But it appeals to me because it's a celebration of teachers. And indeed, Denise and I were intern and resident. We cruised the halls all night at NCB, figuring out in the darkness what it is we were up to. And you all know, all of you, having been teachers to an intern-like person, you all know what it is that happens when the intern looks at you and says, "What do we do next?" And you look back at that intern looking for a glimmer of the answer. That's what happened. So however long it goes from one meeting to the next with Denise Rogers, I feel connected at the hip. As we do, I trust, all with the students who have mattered to us, with the students with whom we've established contact. And that's what I want to talk to you about now, the establishing and maintaining of contact with our students as with our patients. If you ask a faculty member in a nursing school or a school of public health or a medical school, are you a teacher? Chances are they'll say no. I'm a nurse, or I'm a dentist, or I'm a doctor. We don't tend to think of ourselves primarily as teachers, and yet being a teacher is one of the most complex uses of the self. It's a commonplace, you know, when people win the Nobel Prize, they thank their fourth grade teacher. Or when somebody wins the Horowitz Prize, they thank their grammar school piano teacher. That's the commonplace. But in fact, we know the formative powers of the early guides into strange lands, whether it's playing a sonata or operating on a rotator cuff or indeed tapping a belly in a septic patient. And I want to look some at the peril and the transformative power of that relationship between teacher and student. Now, I know a little bit about early childhood education. I was a kindergarten teacher before I went to medical school. I was also a school bus driver, which I think taught me as much. But it was probably the best job I ever had. I'm going to bring us back to being children. In early childhood education, we learn from people like John Dewey and Maria Montessori, these really smart people who have realized that freedom and imagination and creativity in life begins in primary school. They understood the revolutionary consequences of open classrooms, serious play, experiential learning. And what's usually reserved for kindergarten children is indeed the pinnacle and the model for all learning. It's a situation of open movement to and fro through spaces of beauty and comfort, where one is surrounded by sensually enticing materials to touch, to smell, to feel, to hear, to see, where companions gather at will at sites that attract and bond them together, where choice is extracted and so taste is proclaimed. And you know what a well-functioning kindergarten class looks like, I hope. I mean, there's the book corner, and the animal corner, and the algae growing in the kind of disgusting fish tank, and the backyard with the mud hut, right? And the kids, if it's a well-functioning room, there's music, there's color, there's comfort, and there's movement as the children with the teachers and the other grown-ups kind of rhythm their way through learning. The reign of play in a well-functioning primary school is the model, I think, for adult learning. Give us a safe clearing, unthreatened by failure. Give us supportive guides in our teachers who can see a few steps ahead of our current position. Give us some goals that we can ourselves choose to meet. And then you have learning without deformation, learning without fear, and learning without end. You'll have as a dividend, and a critical dividend, and I think that's why you're all in this room at the same time, you have as a critical dividend the formation of a community of learners and teachers committed to what they learn and teach and committed to one another. All right? I am still in touch with now 50-year-olds who I taught how to read. Health profession schools can or should or can be an open classroom. Now, we're not building replicas of the Brooklyn Bridge or making maps of Madagascar in the backyard, which is what we used to do with my 5-year-olds. But our students indeed build at least virtual models, don't they, of veins and arteries and nerves. Where did he go? I just met one of the teachers in the anatomy course at Piscataway. Think of what it is that he helps, there he is. Think of what he helps students to build, right? You're building the structure of that pelvic brim, right? And all that's inside it. They build concepts of acid-base balance. They build concepts of what does the teres minor really do and what happens to the arm that doesn't have a teres minor. They learn how to model, I would hope, healthcare policy and healthcare process and outcome. We teachers are meant to midwife this process of learning. We know enough about the tasks to at least sequence them in some reasonable order. We assemble the material. We understand that we ourselves are part of the process of learning, and this is the critical bit. The student incorporates new knowledge and interiorizes new capacities through the mediation of our relation No lesson is fed to a student with a spoon. Each lesson is taught to a student by a teacher. Now, John Dewey and Maria Montessori talked a lot about early childhood education. People like Parker Palmer and Jack Mesereau have taken their ideas and applied them to adult learning. There's a movement within higher learning, within the university education community, to say we are responsible not only for the content of our lessons, but for the interior of our students. They lament, these innovators, that it's not stuffing empty heads with facts, but rather entering relation with students, students who have ideals and goals and quests. Because we teachers can recognize our students on their quest, the relationships are transformative. They let the teachers let the students become the persons they have the capacity to be. And it's not only because the teachers recognize the students, but they enable the students to recognize themselves. So this is primal, primitive, primordial becoming of self. Yes, it starts with mom in utero, I suppose. But it is in the teacherly relation, the teacherly acts, that our students, at no matter what level, have the trust and the daring and the capacity to become who they are. Now, in healthcare professional education, the enterprise is kind of doubled or tripled in a way that I don't quite understand, and I'm not really sure it's not the same in other enterprises, but listen, what we do with our students is what we hope they will do for their patients, right? Process and outcome are mirror images of one another. So that as I teach a medical student how to listen for a patient's account of self, I am doing for that student what I hope to teach that student to do for a patient. Process and outcome are mirrors, all right? There's a reciprocity between the learner and the lesson, and indeed between the learner and the teacher. Somehow this makes the peril all the greater and the triumph all the greater, right? So, we're talking about relational learning. It's not different from, it's not fragmented from the person who teaches it. Relational learning or transformational learning, which I think are the same thing, is a form of education that establishes contact between learner and teacher. I keep using the word contact. I think it is the key. The contact between learner and teacher changes them both fundamentally. Not static, not dull, not repetitious, not predictable. Scenes of learning are ever new, ever surprising, because the ground of learning keeps shifting. The prime task of the teacher, like the prime task of the clinician, is to establish and maintain contact with the learner or the patient. Over the course of their work together, both participants, this is what we need to know, both participants are elementally changed by the encounter. I feel as a doctor that my patients are in my bones. I feel as a teacher that my Denise Rogers and others are in my bones. It is our students who make us the teachers we are. Think of what we owe them. Because they are not left in isolation, because they, the students, are not abandoned, because they are witnessed by us, they will learn. Now, I wondered why you invited me to give this talk. I'm not really known as an educator. That's not kind of what I do. I'm a general internist. I'm a literary critic. But I think I understand the place in this world for narrative medicine and for the methods that we have developed. I think I can see how the work of my group and I in doing narrative medicine might be an exemplar for certain kinds of experiential learning and relational work that it seems to me illuminates your goals in the Master Educators Guild. So I want to describe some of the teaching and learning that we've been trying to do with an eye toward exposing some of this freedom, this serious play of ideas that I've been talking about as the foundation of successful, effective teaching. Narrative medicine is what we've come to call clinical practice fortified by the knowledge of what to do with stories. We all know that healthcare is saturated with stories. This is how we do the work. The patient comes in and tells you about the headache or the knee pain. The patient's mom comes in and tells you about the asthma in the 5-year-old and how terribly anxious the whole family is. What we do is sit and listen to stories. We cohere them with the other kinds of stories, what I hear from the intern in the emergency room, what I hear from the home attendant when she calls for the refills. The work, what we're paid to do as generalists anyway, is to get the news from these complex, often very contradictory stories that we hear. Before we were nurses or doctors or physical therapists or chaplains or dentists, before we were healthcare professionals, we were always and already persons who understood and participated in the flow of stories. We grew up hearing, I'm bringing you back again to childhood, forgive me. We grew up hearing family tales, religious legends, cultural myths, fictional stories that identify us and shape us. I ask you again to think of yourself as a 5-year-old or a 10-year-old. Don't you remember the books you checked out of the library? I mean, mine were Nancy Drew and fairy tales and horse stories. And I read them by the dozens. And I bet you know what you read as a child. Don't we remember telling stories to one another for pleasure, for attention, for the hearing of them, for the finding out of how they end? The stories we hear in the gospel, the stories we recount every year at family gatherings. Remember when Uncle Joe brought right? The stories we read aloud at Seder. It's the same every year. Why do we read them every year? Why do we want to know about the wise son and the simple son? Well, you know, these are stories that make us who we are. They enlarge us. They connect us to communities of being, so that without the stories, we wouldn't be who we are. We also remember storytelling situations. If we're lucky, we remember when Mom read a book to us as a child. The big picture books that needed the whole lap of mom and kid to open. You and she and the people or animals in the pictures, and even the Richard Scarry or the Beatrix Potter or the Maurice Sendak behind those words and pictures, are entwined in a magical, affectively dense narrating situation. Mom is making herself the corporeal and audio medium for the imagination of the other. The story flows through Mom to the kid, while you, the child, absorb the sounds of her voice, the colors in the book, the smell of Mom's cotton blouse, the feel of her plump thighs under your little buttocks. Am I right? The coziness of having her all to yourself for this period of time. In the process of giving you a story, she gives you as well her attention and nearness and intimate contact. You have her presence. 3 of my medical students wrote a children's book last year. They wrote it 2 years ago when they were fourth-year students. They have an agent. They are soon to be published. It is a children's book about the death of a parent. When they were on psychiatry rotation, they realized that there was lots of materials for parents who lost children. There was a dearth of material for children who lost parents. They understood that a child whose mother or father died would have recourse to the lap, at least, of another grown-up. So they wrote a big format book about the death of the parent that would be read to the child by other adults in that child's life, as much for the benefit of the adult reading it as for the benefit of the child. All right? Taking this most severe and grave and unthinkable tragedy in a child's life and understanding that one vehicle in to the interior of that child would be the reading aloud of a story simply rests my case for the importance of these storytelling situations. Now, so long before we were doctors, nurses, dentists, chaplains, physical therapists, we lived lives saturated by stories. And kind of what happened? On our way toward becoming clinicians, rather ominous things happen. Except for those of us who are writers or readers, really die-hard writers and readers, to begin with, we're not as a rule given much encouragement to develop these skills as the receivers of stories, or the givers, or the tellers of stories. It's quite the opposite. I mean, the English majors don't have such an easy time in the first couple of years of health profession school, right? So we don't get to develop our skills in recognizing when stories are told, in absorbing them, in interpreting them, in metabolizing them, in being moved by them, in fantasizing and imagining all that's going on in them. We simply learn little about what to do with stories. My English major students, the ones who make it in, they get parched. They come to our fourth-year elective in narrative medicine. They can't wait. They said, "You mean, really, is it true all we do the whole month is read fiction?" I said, "No, that's not true. You read fiction half the time and you write it for the rest of the time." Yeah, and they come. Now, what are the consequences of this? What are the consequences of turning away from story? Nurses, doctors, physical therapists, all of us who take care of the physical body seem to get marooned in the body, far away from its self-telling powers. It's a paradox, because those of us who tend to the physical ills of others have to attend to the body, to the heart, to the intestines, to the joints, to the tendons. We have to attend to the body, and yet we cannot risk severing the body from its self. And the self, of course, is the storytelling aspect of that person. I've been writing lately about the self-telling body, because I think that's a way to kind of unify that which goes on within the corporeal frame and its telling identity. The body, we know this, the body is the portal to the self, gaining us access, if we're good at our work, to not just the physical situation of the patient, but the deep, profound selfhood exposed by illness or the ill state. You know what happens when you give a bed bath to a dying person, or when you examine the feet of a very old woman. You hold in your hands the decades and decades of moving through life. It's not only the bunion you are examining, but the being planted on earth that you caress with your hands. I recently saw in the office a 78-year-old woman suffering from lung cancer at the end of a long, rather remarkably successful run of treatment. She had surgery, she had radiation, she had chemotherapy, she had experimental chemotherapy, she had more radiation, and she persisted. It was quite extraordinary. The oncologist didn't quite know what to make of it. I remember diagnosing her cancer many years ago, brought to my knees by the radiology report that first described the lung mass. It was, sometimes you know what you're going to find and other times you don't. And I thought at worst this would be a little infiltrate, and I get the x-ray report and it's a big, big mass. I was brought to my knees. These days, with her advanced lung cancer, she insists on getting her bone density scan, her mammogram. She asks me what can she eat to gain back all the weight she's lost, knowing full well the implications of the weight loss to begin with, while summoning whatever power she has to defy those losses. When I wonder why is she so keen to do these preventive things, I realize that she has a stake in a future that I don't yet see. Either her behavior enacts denial, or, what I think is more likely the case, it reveals an awareness that she has survived far beyond anyone's expectations, and maybe not only by virtue of what we did for her. She comes in one day with a sore foot. I thought it was an Achilles tendonitis. I kneel on the floor in front of her and rub her foot. I spend quite a bit of time there, kneeling, massaging her painful foot and ankle and calf. She says it helps. The next time she comes in to see me, she says I have magic hands. Now, maybe I recognize something in her, but she sure recognized something in me, something that I cherish and will never forget. Any human contact, like this human contact, that results in one person feeling witnessed by another, will allow the witness to grow into a more complete human being by virtue of the contact. Do you see? And I'm talking about contact between here, internist and patient. It is the same between teacher and student. This is the contact we're talking about. This is the mutual acts of recognition that go on. I recognize Denise as the intern growing in skill. She recognizes Rita as the resident who maybe has tapped a few more bellies than she has. And it propels both of us on our search toward self-recognition. Now, I use the word witness. It connotes a wide continuum of things. Sometimes the witness is like in the law court. You know, what did you see on the night of the 14th? Sometimes it's purely a reporting function. Sometimes the witness bears witness. When you give an oath, right? When you read the Hippocratic Oath, you're bearing witness to some ideal. Finally, the transformative potential of witnessing, which is what we've just described, come into view as the witness of another's situation not only stands and sees, but becomes embedded in the situation of the other. So that you're not just a recorder or an observer, but an intimately bound partner, situated with the other now, watching and waiting together with the person who you're teaching, or if a patient whose life is ruptured by illness. You're lending substance of self into the situation to change it meaningfully. The witness is transformed by that experience, now aware not just of powers of observation, but of a capacity to make contact, always new. My rubbing of the feet of my 78-year-old woman declared that I was on her side, on my knees, honoring the steadfast vitality of this woman so close to death. She understands full well the limits of my magic, while I appreciate ever more deeply the courage and grace of her ongoingness. I was humbled by her disregard of medicine's so-called prognosis, as I was enraptured by her cosmic vision of hopefulness amid the despair. Now, all of us know this. We, as clinicians, enter the lives of patients in times of great disruption. We know this. The narrative thread of an ordinary life is interrupted. A child gets leukemia. A senior breaks her hip. An adolescent girl gets pregnant. A grandmother loses her mind. A young mother finds a breast lump. An infant is born with a damaged heart. We enter into these complex narrative situations having to imagine what the situation must be like from the inside. I just put in a grant proposal to do some writing work with the parents whose unborn child has been found to have severe cardiac defect. So the fetal cardiologist discovers an aplastic left ventricle, a horribly congenitally deformed heart in the fetus. And then the parent, and this is 12 weeks, and then the parent has to somehow, I don't know even what verb to use, live through this pregnancy. So we're doing some writing work with the parents and with the fetal cardiologists to see if we can't ease that journey with this horrible uncertainty. And that's helping them to imagine the situation, all right? The better we can attend to the complexities and the better we can, in fact, become helpers or co-narrators for patients of what they're enduring, the better we can accompany them through this illness. And then offering, by virtue of that, the best possible technical care. Now, we know the benefits, I trust, of being or helping others narrate their own loss, their own trauma. The post-traumatic stress syndromes that we hear about, some are the dramatic ones, where testimony has to be given, yes? I'm thinking about the Truth and Reconciliation Councils in South Africa after apartheid, or the village councils in Rwanda after the brutality of that war. But this kind of need for the person who's undergone loss or trauma to tell of what happened to him or her is present all the time. Every headache clinic in New York, every domestic violence clinic in any city, every irritable bowel disease program needs some means by which those who suffer can tell of what has befallen them. So you see, I'm just trying to give you reason after reason why it is that we have to recuperate our knowledge of how to receive stories, how to help others tell them, how to tell them, right? These are all situations of the need, the urgency of doing this. Now, one means toward this skill of being an able, responsible receiver of others' stories is indeed to tell one's own. And to tell one's own in writing. We know what happens when you write. When you write, you're able to take formless, chaotic experience. Say I'm meeting with a group of students and the ward team has just had a terribly messy cardiac arrest. You've been at, the code. And everybody runs to the code and they pump on the chest and they put things in various orifices and there are lines and and then, of course, the patient dies. And what happens? Certainly the nurses, doctors, respiratory therapists in the room know what happens next. You know what happens next? Everybody leaves. Am I right? Everybody leaves. Eventually, it is the nurse who will go back into the room, who will remove the endotracheal tube, who will pull out the femoral line, who will take off the EKG bracelets, who will bathe, who will clothe, who will drape that corpse and let the family come in and mourn, right? The rest of us just get out of there. So when I meet with the students, I say, well, what happened there? And they're all kind of shell-shocked. I tell them, write it down. Take the next 4 minutes and describe what happened in that room after that cardiac arrest. And it's only when they write it that they see it. This happens all the time, no matter what the trauma is. You write it and then you see it. You confer form on a formless, chaotic, hot situation, and then you can see it. Then you can turn it around. Then you can say, oh, that's why that was so hard. Then others can see it. So this is what we do. We go through the medical center helping people write about what they undergo. When I described the office visit with my patient, I placed myself spatially with this woman. I went out of my way to describe our spatial relations. I was on my knees in front of her. Now, being on one's knees, washing or holding another person's feet, has implications, doesn't it? It has implications. So that makes me the Mary Magdalene, the fallen woman, to her Christ, doesn't it? I mean, this is what happens when you tell stories. Just writing that little description let me confer form onto what was up until then a formless memory. I chose a way of writing it. I chose the words. I drew the frame around it. I didn't mention her oncologist. I didn't mention her daughter, who indeed was very difficult. I set a temporal frame. I told you all the way back to when I first found her mass, right? Implicating me in the condition from all the way back. Reading it myself and then reading it to others canonized the event. It made it something valuable, memorable, memorialized. All right? So that's the method that we use in narrative. We go all over the place writing with people, nurses, doctors, social workers, chaplains in oncology, in HIV, in the emergency room. And it is in the writing together, and this is where I want to close. It's the writing together, crossing those disciplines, that has great, great power. When we do these things with mixed professionals, the way you are in this room, when we write seriously about these experiences in healthcare of our patients' illnesses, we get very quickly under those distinctions that usually separate us. It's natural, it's automatic. We get under those distinctions because indeed we are writing about the elemental ground of suffering. All right? We're able in these writing groups to form what I've been thinking of as clearings. And I want to leave you with an image of this room, perhaps, as a clearing. As we do this work, it is as if the stories of illness are a campfire around which we all sit, in the semi-darkness, our faces illuminated and ourselves warmed by the glow of the telling. The work we do in narrative medicine, and I suggest work that one can do in any groups of mixed professionals. We create a space where clinicians and patients and scholars can meet, can congregate. We've opened up what feels like a clearing in the tendentious terrain of health and illness. It is as if in among the dark oaks and the thorny brambles of the ignorance and the unfairness and the uncertainty of illness and all the antagonisms in healthcare, we have cleared a space. Do you see what I mean? It's like the forest, a dense forest, and we sort of clear a space in the darkness. I see it as mossy, as spring-fed, as fern-softened, green clearing. It's a clearing of safety and beauty, of protection and affiliation. The clearing attracts persons. It gives them a place to stand together, bringing together all who are implicated in and influenced by and powerful over illness and care. And in a space like this, and in a space like this, it seems to me we can attain the unity needed to help solve problems in healthcare, and so desperately absent most of the time. We are, in the beginning and end, passionate, creative human beings who are committed to health for patients and ourselves, and committed to learning for students and ourselves. And they're always all together. In profound ways, the two goals, the caring for the ill and the teaching of students, are identical. We have within us deep wells of commitment and humor and knowledge and imagination and affinity with those we care for and about. I've described to you some methods of narrativity and storytelling that give us methods to near our patients, to near our colleagues, to near and make contact with our students, to join with them all in the effort to be well, to get well, to stay well, or to grasp what being well or ill might mean. I think this is our mission and our hope, and I think that we are getting good at it. Thank you very much.